For those of you who haven't met me, I'm Ant Kitchener, and my background is general practice, a paramedic by origin, but more so an ACP in general practice for the last 10 years. And I do dabble in a bit of education and a bit of clinical management as part of my ACP portfolio. And tonight I'm going to talk about some of the reproductive and sexual health bits and pieces which crop up in primary care mainly, but I'm also going to start thinking about what if I get a presentation outside of primary care, why does this as a consult start to bear fruition? Why should, for example, in an emergency care setting, I think about a reproductive and sexual health history? And why should, in a hospital setting, for example? So often these things can triangulate because actually patients can go anywhere in healthcare, but the majority of cases around reproductive and sexual health are managed in general practice. And we will talk about some of the support services out there. So if I was just to give you a list of common consults, the things which, bread and butter, gynae consults that we see in general practice, day-to-day stuff, contraception, and we'll do contraceptive reviews, thinking about the bad things which can go wrong with contraception. So we think about VTE risk of clots. We think about migraines, and we think about whether that's the right approach, and lots of different contraceptive options. Everything from long-acting reversible contraceptives through to the COX and POPs, the combined oral contraceptive pills, the progesterone-only pills, and then things like implants and intrauterine devices. So a common consult is both how we prevent pregnancy. We do use them for other things apart from prevention of pregnancy, but predominantly the risks associated with that and the way forward in terms of prescribing for contraceptives. Now that in its own right is a whole thing you can go off and study, and it's reasonably complicated actually, and there's some really good online stuff from the e-learning for health and from the faculty from the Royal College of Gynaecologists, the Faculty of Family Planning, etc. I'm not going into contraception too much, but I'm going to focus more about the other elements. A common consult is vaginal bleeding, both the kind of normal period type vaginal bleeding, but also when that goes heavier, wrong, or different. Everything from menorrhagia, that heavy periods, to amenorrhea when females are not getting periods. And when we start getting these periods which come and go, irregular, don't have particular patterns to it. And what does that actually mean? And is there underlying pathology behind that? Vaginal discharge, that includes, we get consults around physiological discharge. Every female has a physiological discharge to a certain extent, but when does it become abnormal? Thinking about that history, it says vaginal on there, so say vaginal, so excuse the typo. Dyspareunia is painful intercourse, and why is that important for history? And I'll touch on that. These two important questions, PCB, post-coital bleeding, intramenstrual bleeding, really important documentation questions to be thinking about, and I'll say why in just a moment. Incontinence, infertility, pelvic pain, and itchiness around the vagina is another common presentation, and that includes postmenopausal as well as premenopausal presentations. So as a bag of presentations, it can be quite diverse. Sometimes you get several symptoms together, and actually you need to piece some of these together in terms of your history take and also a physical examination. Now, no way are we telling you about how to do physical examinations and qualifying in such things here this evening, but it is fair to say that your history take, combined with a physical examination, combined with your the rest of your history, can often point you in the right directions of which conditions related to gynaecology that you could pick up on or support. And for me, there's several categories in my head. There's the bad ones, the cancers, and there's 5 main cancers, and I'll talk about those in just a mo. But I don't want to miss a cancer because actually that can be really, really impactful. And we know later cancers are left. The potential is that it might get to a point where it's non-retrievable and you can't treat it. And then the element down from that in my head are those that are problematic. And a number of these things on the screen are problematic for the female, and it should not be underestimated how impactful these problems can be on everyday life. They can make people and patients absolutely miserable, really impactful, and therefore we should not underestimate the impact of their symptoms and how we support them to manage that. And obviously, being a spectrum of presentations, we've got some that are very insidious, really hard to spot, diagnose, to those which have got some very occult and common presentations that we can easily pick up on. So it's just about using your Sherlock Holmes approach, doing your investigation work and trying to get to a point that you're confident, or at least refer on if you're not confident around the potential problem that you've got in front of you. So let me talk cancers to start with. So I always think if I get a female presenting that've got certain symptoms, I think about the cancers, and I want to make sure that cancers are on top of my list to rule out. And I always hold my hand up and the patient thinks, what am I doing? But actually I'm just counting in my head, have I thought about the 5 different cancers that potentially could be going on in the gynae sphere? And I think ovarian, I think womb cancer, uterine cancer, I think cervical, I think vulval, and I think vaginal. So these are the 5 areas that I really think about that I don't want to miss. So how would I spot a patient with a potential cancer? And these are the ones that potentially want to send on a 2-week wait for rapid diagnosis, rapid intervention if it is the case that they have got cancer, or at least an exclusion to say, good thought, but actually it's not. And therefore we can look at a different cause. Now, what I will say is just bear in mind that just because cancer has been excluded within the gynae section, under that investigation, or maybe in one of the areas, it does not mean it might not be another area. So always follow up. Pro tip number 1, always see back your patients you put on a 2-week wait, because if there's something that had you worried in the first place, it's worth following them up so you don't miss out. So ovarian cancer. So we know the ovaries, the place your eggs are made and released into those fallopian tubes. You should have 2 of them as a female. How can we know someone's got ovarian? This can be a really troublesome presentation. So it's more common in the older female, more common. We know that IBS type symptoms late onset in life can be an ovarian presentation. So if you've got an older lady, or any lady within those 40, 50, 60 age range, maybe even a little bit higher, that is starting to get IBS symptoms, so bloating particularly is one to think about, but constipation, and you think it might be IBS, start asking yourself, would I see IBS commonly in the older female? And actually, it's more of a younger person's presentation, and often people, get that diagnosis earlier in life. So if you have got that older lady presenting with new onset IBS in later life, think about ovarian cancer, because it's really insidious, it's difficult to spot. But, other symptoms including persistent pelvic pain, abdominal pain, a feeling of satiety, so they feel full up, commonly full up. That can be a symptom, difficulty eating associated with that. Sickness type feeling, nauseated, and if they're getting that urge to urinate because that ovarian cancer is big, that again could be a symptom. We do have a test for this, the CA125 test. You can think about your sensitivity and specificity and whether it's good enough. And actually, I've known patients to present with football-size ovarian tumours, massive, no doubt you put your hand on it, you're like, gosh, and also really, really subtle. So a difficult one to spot, so be suspicious. Uterine cancer. Bleeding in between periods, particularly after menopause. So if you're got bleeding post-menopausal, that is a cancer until proven otherwise. And, you know, 12 months post-menopausal, you should not be bleeding at all. And so if you're getting new onset of bleeding after they've been through menopause, that is a uterine cancer until proven otherwise. If they are premenopausal and having periods, it might be heavier periods. That is the symptom of that. And they can get discoloration of urine, sometimes a pink stain, for example. In terms of vaginal cancers, obviously slightly lower down that track. Again, we talked about that, that post-coital bleeding and intra bleeding, so between the periods, into menstrual bleeding. And again, that can be a sign of that. So bleeding between periods, bleeding after sex can be a sign of vaginal cancer. So we should keep that in mind. And also that dyspareunia, that painful sex, again, can be a sign of vaginal cancer. And again, if you've got a lump, which you might find either on examination, you visually see it by a speculum examination, or in palpation, again, that could be a clue there. The other one that I sometimes think about is persistent itch. So if you've got persistent vaginal itch, again, that could be a sign of a vaginal neoplasia, a cancer. Vulval cancer, so more towards the opening. Again, itch is a common sign of that. So a lasting itch, you can't get it to go away. You've tried some common treatments and it's not going away. Persistent soreness, persistent redness. And if you're getting thickened, raised patches of skin around the vulval area or a lump in the vulval area, again, you can think about whether that is a potential referral criteria for this. In terms of cervical cancer, so up on the cervix, again, your bleeding history will be important. So bleeding between periods or after sex again. Discharge, so you might be getting a foul smelling discharge, that pungent discharge. And, you know, you've got to think about what you see. So if you do a specular examination, can you actually see anything around that? And we talk about acetyl white changes. So, you know, if you imagine the cervix kind of like a pink circle and potentially the walls around it, does it look like someone's popped a bit of Tipex on it? Like a white change actually on your visualization. So broadly, there's a number of symptoms, but actually they can be a number of things. So it is a difficult one to spot, but the only way that you'll spot this is by having that index of suspicion and bringing your that thought about cancer into your mind. Hold up your hand. Have you thought about the 5 different areas of cancer around ovarian, uterine, cervical, vaginal, and vulval cancers? Now, the ones which I'm just going to give you some pro tips again. Ovarian, unilateral leg swelling. So if they're getting one leg swelling up, but not the other, unilateral, that could be a clue. And unilateral lymphadenopathy, so glands up in the groin, again, that could be a clue as well. And also I think about these group of cancers, about their risk of VTE. So if you're presenting with clots somewhere, have you thought about the origin of the clots? Is there a cancer ongoing in the background? So interesting thoughts. Cancer is always on my list of reproductive and sexual health things I don't want to miss. So then the next category down was about those problematic ones. And I just want to talk about vaginal bleeding. So for me, vaginal bleeding is either a localized issue or the vagina is a window to other pathology. So sometimes people can bleed vaginally because there's other issues going on in the body elsewhere. And I'll give you an example. You could have a hemoglobinopathy, a blood clotting type disorder, and actually the presentation is vaginal bleeding because you're not clotting properly. And you know, you might just need to think about, is the problem local? Is the problem systemic? And what you don't want to do is to get blindsided into just a localized problem when actually it could be a problem in the background. So is that a a window into the body, giving you a clue that there's other pathology going on. But then actually when it comes down to excluding it, or at least getting down your differential diagnosis, it's a tough cookie again, because there's lots of things going on. And your history take here will help you. And we've talked about excluding the red flag ones around the cancers, and I say ovarian cancer, womb cancer, cervical cancer, vulval cancer, vaginal cancer, the 5 cancers. And, there are ways to investigate. So we have got blood tests, for example. We can look at anemias. We can look at our clotting factors, the hemoglobinopathies. We could do potentially hormone levels. We could look for cancer markers as examples. But what I just want to demonstrate is actually it is a tough cookie to get an accurate diagnosis sometimes. And actually a lot of these you will pick up in history, so a very comprehensive history, and combining with a proper examination. And an examination might be a speculum examination, combined with a bimanual examination to check for things in the adnexa, the tissues surrounding the uterus, fallopian tubes, the myometrium, for example. So it is tough to get a diagnosis, and often there are ways that we approach bleeding problems, bearing in mind that the body has a natural way of regulating vaginal bleeding, period type bleeding. Now, if you're bleeding, say, from an ulceration inside, it won't necessarily get better with hormonal type preparations. And sometimes we do see cyclical type changes. So, for example, with the period cycles, does the bleeding get better and worse? And actually things like fibroids, for example, you may get changes within that cycle as well. So really what I wanted to just describe is actually it can be a tough cookie to get an exact diagnosis around this, but it is worth thinking about all those questions. And do you take a comprehensive history? The other thing I want to think about is the vaginal bleeding presentation the alpha presentation? Is it the one that they're coming to you saying, I've got vaginal bleeding, that's an issue, it's heavy, it's irregular, it's gone, is that the presentation? Or are you getting some other presentation and your history takes you back to examine this? And I'll give you an example. If you think about the loss of blood, vaginal bleeding, that will lead to an anemia. The biggest, most prevalent cause of anemia in the premenopausal woman, menorrhagia. And what could that present clinically? Well, actually, we know anemia could present with chest pain. In the pre-hospital world, chest pain is a common presentation, with palpitations, with syncope, with breathlessness, for example. So actually, you might have one of the presenting complaints that's not gynae at all. But actually, when you start to think about, okay, I've got a female, I've gone through my biomedical history, and I start to think about, can I trace this back? The origins of my presentation, is there something in the gynae history that makes me think, is it anemic? Okay, if it's anemic, what's then the cause of the bleeding? And that Sherlock Holmes piece around detective work, back tracing, can actually start to come to fruition. And it's important, as well as the gynae history, the pregnancy history is really important in there, and their sexual health history. So what type of behaviors, risk patterns do they have in their current life and past life, bearing in mind that some things like sexually transmitted diseases can linger for 20+ years. I've certainly had stable relationships with only one person for the last 15, 20 years, and they suddenly develop a case of herpes, for example, and it dates back into their long history. So interesting. So I'm just going to take you around a bit of a tour around support teams, just to add some context to this, because actually I said the predominant amount of these present to general practice, primary care. Some of the other symptoms, symptomology of vaginal bleeding, that heavy periods, for example, present to pre-hospital worlds, to A&Es. But there are teams that pick up different elements of these depending on which pathway or where you're questioning, your examination, your blood tests, potentially ultrasound scans take you down. And there are a few that will just be managed within primary care. And I will just mention that bleeding is an endocrine disorder as well, to a certain extent. So you've got to think about your brain chemicals, so the ones that are released from the brain that might affect it, including your follicle stimulating hormones, your luteinizing hormones, for example. Your local hormones around estrogen, progesterone, and what that looks like, and testosterone to a certain extent. And then also the other hormonal presentations that might have an effect on it, thyroid, for example. So low thyroid might make your periods irregular or even knock them out. So again, the cause might be a hormonal cause, even if it's not a gynae hormonal cause in terms of the origins. Okay, so let's talk about wider support teams. So who are your go-to helpers? Who can you consult and take advice on? First of all, for people that are pregnant, around the gynae history, obstetric assessment units. So, people within the NHS, they do get scans and tests that look at the development of babies, and that can be really helpful. Thinking about particularly in pregnancy around your risk of preeclampsia, for example. So your preeclamptic triads, your hypertensions, your edemas, your proteinuria, always worth thinking about, but also the history that you get from sonography. So, they will get scans through the pregnancy. So it's useful to know what they've got, and including the risks that have been assessed through the pregnancy. So they may be some sources of information that help inform your opinion. Obviously, ruling out pregnancy is one of the things that we need to do, particularly if we think about the risk of ectopy, so abnormal growths outside of the uterus in terms of pregnancy, particularly fallopian tubes, very risky, and the risk of rupture. Other friends, so other end of the spectrum. So if you're thinking about those that are due to give birth, we can think about the labour ward. There's midwifery colleagues on there that can give us advice around these. And, often we have ladies that have got concerns, particularly around fetal movements, for example, pains in later pregnancy. So again, they may be good colleagues, and often these have self-referral pathways in. I'm not going to linger on labour wards too much, but just worth thinking, if I had to phone a friend, which ones should I go to? So the sonography is routine, labour ward might be if there's problematics, or obviously if, we've got rupture of membranes, for example, waters have broken. It's really useful to think about early pregnancy though, and I've already mentioned the risk of ectopic pregnancy, and early pregnancy scans can be useful. It's really useful to think though about what questions you'll be asked if you phone these up, and you want to put someone in touch with an early pregnancy assessment unit, because they will probably have a set of questions they want to ask you. So it's really useful to have your answers prepped before you make that call or your referral. So it's really useful to know about what your local system will be asking for. Now, self-referral is often the case into services like this. So ladies can often self-refer even if they don't need a HCP referral in, or you can refer them in. Miscarriage is an interesting one because really early on, less than 6 weeks, it's whether you'll get anything on the scan is debatable. Sometimes it can be small, but some people will just say repeat a urine HCG in 7 days' time, and see what the outcome is, rather than going through this. But it depends on the anxiety and the worry, and often this is a scan to relieve anxieties in some cases, because it can be obviously worrying. If I think about my local unit, I've just gone onto their website and just Googled their referral criteria. And it's really worth having the answers to these. And you know, you potentially will do this referral, you'll get asked these questions. So it's really useful to think about that ectopy history. So what they've had in the past, fertility, have they got a PCOS, a polycystic ovarian syndrome? You know, for example, all of these types of things. Have they tried things like paracetamol, Cetal? And unless they're peritonitic, they may not do the scan the same day. It might be the next day or even the day after, potentially. So, you know, it's not necessarily an immediate referral into this service. Obviously, if they're peritonitic, you think they've got a ruptured ectopic pregnancy, that's different, that's emergency surgery territory. But if you're worried it could be, you know, this would be a useful service. The other places ladies could go, so we could do a referral into just a general outpatient, so obstetrics and gynae outpatients. A lot of this will often be managed in general practice, but again, it could be that second opinion or, you know, an expert opinion if you don't have those services local. Bearing in mind that many GPs have done the diploma in reproductive and sexual health and have an element of expertise in primary care around this. So we'll often we'll have a level of management locally. Endometriosis is often one to think about. So endometriosis is when you get epithelial uterine cells that are grown outside the womb. So somewhere weird or wonderful, not wonderful, just weird actually. So outside the uterus, and they're given problems, often something that takes ages to get a diagnosis on because we don't always have it in our forefront. And abdominal pain and sometimes changes in bleeding can be associated with endometriosis. And they say about the diagnosis and management of menopause, again, often that can be managed in general practice settings. So it's the more complicated cases that will often go there. So other outpatient departments, so there is Eurogyny. So this big picture on here is a picture of a prolapse. Eurogyny clinics tend to pick up vaginal prolapses and deal with incontinence. There are options in general practice again, so we could think about these uterine rings, whether we put something in there, so these kind of support pessaries, whether that's enough to keep things in and support it. We can think about exercises and Eurogyny physiotherapy, whether, you know, your pelvic floor exercises and your approaches can strengthen this. But ultimately, there are also surgical options around this, and whether this needs resiting and stabilizing in terms of a procedure to stop it coming out. Again, incontinence is really common post-pregnancy as well. And again, that's something that in terms of you know, local management, we could think about input from a local Eurogyny physio to help with that. So yeah, there are different pathways. So a lot of this history is about, you know, can we deal with it locally versus, you know, if I had to phone a friend or refer on, who would be the best person to send it to and which appropriate clinic. I mentioned about subfertility. So subfertility is usually a pairs game. So generally we refer people as pairs. And actually the problems with this can be either male or female. Generally, it's easier to investigate the male, so the amount of tests required are less, so usually a sperm sample. So if we're doing a sperm analysis, that needs to be taken and done quickly. So, you know, they, in essence, deposit their sample into a particular pot, and that has to then be looked at under a live microscope. So they generally take it down to the clinic on the same day within a short period of time, and they assess it there and then to look for both the morphology and motility, so the shape and speed of their little swimmers, their sperm, to see whether they have a low sperm count or an abnormal sperm count in terms of whether that could affect it. And obviously you can also work up testosterone levels in the male if they've got any form of erectile dysfunction that's contributing to that. And in the female, it's slightly more complicated, and they will want things like have they had a pelvic exam to make sure she's structurally okay? Has she had a workup in terms of ultrasound scan? And have we done hormone profiles to make sure that they're all prepared and ready? And depending on your local service, some want it within particular cycles, and some just want a one-off. It depends which service you've got, to be honest. But when you think about the referral for this, it's really useful to sit a couple down together, if it's a couple that's presenting, and actually have that conversation about all the processes that need to take place. The NICE guidelines have got some very, very clear guidance around this. So typically it takes around 2 years for someone without any pathology to conceive, and that can be normal. So typically we ask for this 2-year period, unless there's some exemptions on that list. So if they've got known pathology, so for example, they've got a background of cystic fibrosis in the male, and we know that congenital vas deferens changes can be a problem. So therefore, waiting 2 years isn't going to make a difference. And again, in the female, there may be examples in there again. So if it's a male problem, it tends to go to an andrologist, and that's usually a type of gynecologist, actually. So it's often useful just to refer them into an infertility clinic so they can do the triaging and send him. And actually, the success rates are varied with infertility, and if you're interested in that, certainly worth having a read around. A couple more bits for me just to talk around before we finish up. Colposcopy clinics. So we do a number of things to prevent cancer in NHS Health. So obviously we vaccinate around certain viruses that can contribute to cervical cancer. And we also do cervical screening in terms of smear tests or pap tests. And what these smear tests, under a speculum examination, we put a little sweep brush in, twiddle it around, we try and get some epithelial cells on that brush, send it away, and we look for cervical intraepithelial neoplasia cells, so CIN cells, to see if there's any changes. And actually, depending on those changes, would be whether you get referred into a colposcopy clinic, and there's different levels of this dyskaryosis, these epithelial cell changes. CIN 1, which is a mild dyskaryosis, CIN 2, that moderate dyskaryosis, and CIN 3, that severe dyskaryosis. And CIN 3 can be quite full thickness of the cervix, actually. So, and depending on that, you'd go to the clinic, you'd have your colposcopy, and they'd biopsy, they'd take a bit and examine it under the microscope to see if there is any cancer there, and the treatment would be there accordingly. And then the last two I just want to talk about. Community and sexual health clinics. So I've mentioned about sexual health history being really important. Here's a picture of some anal warts that you've got there. So a type of genital wart, a type of herpes. So getting your history is important there. And just bearing in mind that, as I said, sexual health presentations can linger and can be asymptomatic as well. And we can think about the things that we screen for: chlamydia, gonorrhea. We can think about presentations for warts. And discharge, typically abnormal discharge, I've mentioned about physiological discharge, is often a gum issue. So we need to think about those sexually transmitted infections when we're getting green, brown, smelly discharge. Obviously, you can get thrush, which is reasonably easily treatable. And what I'd say with vaginal thrush is just be wary about colonization, because often it can colonize around the anus as well as the vagina. So pessaries don't always do the trick. So there are vaginal pessaries to treat thrush, but if it's colonized in the anus and they keep getting reoccurring, particularly if the wiping history is a little bit off, then actually they can just get reinfections. So often And actually my preference is I tend to treat with oral presentations of thrush treatment if they've got problematic presentations because of thrush. Thrush isn't a sexual health problem per se, but it is worth just thinking about that. But otherwise, discharge, think about whether a sexual health clinic is warranted. And again, you can think about those risky health histories and the other things that would be picked up around this HIV as an example. And then when it comes to the community, you can just think about the community teams that can support you. And, we've got some awesome community practitioners out there. So obviously your midwives, postnatal midwifery support for preemie babies. There's, the prem teams out there that do home visits. We've then got right up to our health visitors that look after those up to school age. And then from schooling ages onwards, we've got our nursing teams within the school, so the school nurses. And actually they can be a real source of help, support, reassurance. And the other thing is to think about triangulating our information, particularly if you're thinking around safeguarding or developmental concerns. So just bring this together. So for me, it's really important to think cancer when it comes to gynae histories. And I've said about that five areas of cancer that we should think about: ovarian, uterine womb cancer, cervical cancer, vulval cancer, vaginal cancer. And that is complemented, your diagnosis, by your history, a really comprehensive biomedical and sexual health history, as well as physical examination, speculum examination, bimanual examination, and that may be further complemented by imaging or biochemistry to help support your diagnosis. The next level down for me was about problematic presentations, and vaginal bleeding is one of those that is a common consult. And I said about, remember, thinking both local, but also is that a window into the body to think about, is it another disease that's presenting in such a way via the vaginal tract. And then finally, I finished up by just talking about some of the phone a friend support services and where we could go with some of these presentations should you get stuck or it's not treatable with the local resource, knowledge and expertise that we have within general practice urgent care. And I will just remind people that I mention a lot about primary care because that's my background, but there are a number of presentations that we'll present to other colleagues, and it's really useful sometimes to think about, is there a gynae cause to this, including from anemias, because they can present with a whole myriad of clinical symptomology. So I'm going to finish there, and I'm happy to take questions where I can to support you. So I'll just stop sharing my screen and then we'll come back.